Good afternoon, good afternoon, good afternoon. My name is Daiquiri Robinson, and I am the chair of the University of Pennsylvania Center for AIDS Research Community Advisory Board. And I just want to say to you on behalf of our board, welcome to the city of brotherly love and sisterly affection, the home of the Liberty Bell and the Reading Terminal, and the neighborhoods all welcome you. From West Philadelphia, born and raised, to the hilltop hustlers of Overbrook, from North Philly, South Philly, Mount Airy, Germantown, we welcome you. Today is all about community, and we hope that you're here to learn and to glean from one another. I just want to say to you, for all the Philly cheesesteaks and the tasty cake and the Philadelphia pretzels and the water and the EAGLES Eagles, we welcome you. So please sit back, relax, and enjoy the day with us here in Philadelphia. Even though we're virtual, we just want to send to you that Philly love. And now you will hear from Dr. N3C. Thank you.
In 2011, a small group of community-minded advocates from 13 CFAR CAS met in a conference room here in Philadelphia at the University of Pennsylvania. We shared best practices, helping each other with technical assistance, and process and structural development. Once connected with each other, we knew there was an opportunity for growth and expansion, that there was an obligation to develop additional resources which could generate advancement and improvement and foster collaboration. Fast forwarding, welcome to the 10th annual National CFAR CAB Coalition meeting and our third annual community symposium. It is because of you and your commitment to community that we are here today. As you participate in this virtual meeting and the various sessions, take time to reflect on why you are here. Now, over the years, I know why I'm here. I value the lessons. I value the conversations. I value the sharing of best practices. And I value the relationships that HIV research and community have developed. I want to thank you for being here and again, welcome you to the National CFAR CAB Coalition Community Symposium. And it is my pleasure and honor to introduce Dr. Denise Johnson, the Pennsylvania Physician of Health for the Department of Health for the Commonwealth of Pennsylvania. It is my honor again to introduce Dr. Johnson.
Hello, I'm Denise Johnson, Pennsylvania's Acting Physician General. I'm honored to be addressing the Center for AIDS Research Community Advisory Board virtually during your annual meeting. Since 1981, more than 62,600 residents of Pennsylvania have been diagnosed with HIV disease. Approximately 27,000 of these persons have died, and an estimated 36,000 are currently living with the disease. Thankfully, the proportion of people with HIV disease who have died has declined steadily since the mid-1990s. In Pennsylvania, the number of newly diagnosed individuals peaked in the early to mid-1990s when almost 3,000 new diagnoses were reported annually. In 2019, fewer than 1,000 new diagnoses were reported. It is also estimated that in the year 2025, the annual number of new diagnoses of HIV infection will be in the lower 600s. Significant advances in HIV prevention and treatment, such as pre-exposure prophylaxis or PrEP, antiretroviral therapy, and the determination that undetectable equals untransmittable, or U equals U, have helped reduce the risk of acquiring HIV and has also allowed those living with HIV to live longer and healthier lives. This progress is certainly to be celebrated. However, there is still much work to be done to eliminate HIV-related stigma and disparities and end the HIV epidemic. Although a person can acquire HIV at any age, the majority of new diagnoses occurred in persons who are between the ages of 20 and 49. Since the inception of the HIV epidemic, Pennsylvania has been committed to the fight to reduce the impact of HIV disease on Pennsylvanians through proactive HIV surveillance, prevention strategies, including linkage to care and identification of partners, and referral to the Ryan White Part B services. The number of newly diagnosed cases is on the decline in Pennsylvania, due in a large part to the concerted efforts of the HIV prevention and care programs and HIV surveillance activities supported by the department. The department receives approximately $7 million a year in funding through the Centers for Disease Control and Prevention to support HIV prevention strategies and HIV surveillance activities. These prevention strategies include identification of individuals at high risk for HIV infection through our clinical and non-clinical HIV testing program. Our program includes HIV testing in both community settings and clinical settings. The program identifies individuals at high risk for HIV infection, including men who have sex with men and persons who inject drugs, and offers testing, risk reduction counseling, and linkage to care. The department also has a network of field staff, including local health department staff, who conduct partner services that allow us to identify individuals who may have been exposed to HIV and provide them with testing and linkage to care or PrEP as appropriate. In 2019, we conducted 95,365 tests through our testing program, with 153 confirmed new diagnoses. In 2020, we conducted 55,419 HIV tests, with 119 confirmed new diagnoses. Note that our numbers for 2020 were not quite as high for the number of tests conducted due to the COVID-19 pandemic, but our rate of confirmed new diagnoses remained comparable to prior years. The data has compelled the Department of Health to examine what testing activities are yielding the best outcomes and how to improve upon the testing activities. Our PrEP program is another prevention strategy that is used for individuals at high risk for HIV infection, but who test negative. PrEP is a drug regimen that, if followed, prevents individuals from acquiring HIV. From January to June 2020, 83.5% of individuals who tested negative for HIV were screened for PrEP services in Pennsylvania, compared to the national average of 61.4%. And of individuals who tested negative for HIV, 53.5% were referred to PrEP services, while the national average was 18.1%. Our prevention activities also include Date to Care, also known as D2C, which is a strategy to use data from multiple sources to identify individuals who may have fallen out of care with the goal of re-engaging them back into care. Unfortunately, D2C services were mostly suspended in 2020 due to the pandemic. However, in 2019, we identified 46 people who fell out of care and were successful in re-engaging 16 of those individuals. In fact, as of December 2019, 91% of those re-engaged into care have remained in care. Finally, the HIV surveillance and HIV prevention team work collaboratively in the ongoing monitoring, identification, investigation, and intervention of HIV clusters in an effort to prevent an HIV outbreak in Pennsylvania. The department receives funding through the Health Resources and Services Administration for the coordination and delivery of HIV care and support services through Ryan White Part B federal grant. Part B funded services include medication assistance, outpatient health care, oral health care, health insurance cost assistance, home and community-based health, mental health, medical case management, emergency financial assistance, housing, medical transportation, and treatment adherence counseling. About $30 million a year is allocated across the regions, and with this funding, approximately 14,618 individuals are served by Ryan White Services in Pennsylvania. Pennsylvania offers an extensive and comprehensive AIDS drug assistance program called the Special Pharmaceutical Benefits Program. Services under this program include medications for HIV and related opportunistic infections, lab services, and Medicare Part C and Part D premium assistance. The Special Pharmaceutical Benefits Program maintains a customer service line which handles an average of over 1,200 inbound calls per month, assisting customers with accessing life-sustaining medications, laboratory services, and providing information on eligibility and a host of related questions. The department also provides housing services to individuals living with HIV through both the Health Resources and Services Administration, or HRSA grant, and the Housing Urban Development, or HUD, Housing Opportunities for People Who Have AIDS, or HOPWA grant, which is approximately $3 million annually. In 2020, 602 households received housing assistance through the HUD HOPWA program, and 98.64% of all clients received HOPWA housing assistance established or maintain a stable living situation, a major contributor to retention in HIV care. The department has a long-standing HIV planning group whose membership consists of stakeholders from across Pennsylvania who assist the department with integrated HIV prevention and care planning as guided by the federal funders, the HIV National Strategic Plan, and the National Ending the HIV Epidemic Initiative. As you can see, there's a plethora of work happening in the field to address and improve HIV care in Pennsylvania. I would like to sincerely thank the Center for AIDS Research Community Advisory Board for your continued work in this space. Together, we are committed to ongoing management and improvement of HIV care in Pennsylvania.
Good morning, good evening, good afternoon. My name is Carol Rogers, and I'm a member of the CFAR CAB at Penn, and I'm so proud and grateful to Daiquiri Robinson and Andre Ford for their leadership. They've not only led the NC3 to what it is today, but also us at the Penn CFAR CAB as well. And as a CAB member, I was at the first founding NC3 right here in Philadelphia. I'm excited to welcome you to this panel presentation on health disparities and health equity, and to welcome you to our beautiful city. We only wish you were here in person so you could enjoy the vibrancy and resilience of our communities.
Yes, somebody else.
No doubt, you'd also see our shameful health disparities in full view in the data that will be shared here today, and in the many faces you'd see on the streets of our city. Faces beaten down by their struggles to survive, and how hard it is for so many to realize the full potential of their lives. The promises of quality healthcare, of research conclusions fully implemented and accessible to all, and of everything people need to live safe and healthy lives, so out of reach for so many in Philadelphia, across this country, and across the world. In the words of Ta-Nehisi Coates, in America, it is tradition to destroy the Black body. and when people have dodged the clutches of the prisons and jails that were built for them, who are we to deny them? Who owns healthcare? Who owns the life-enhancing potential of research? Who owns life-giving resources? It is really such a pleasure to introduce our esteemed panelists, warriors working hard to make things right. At the end of their presentations, they'll have a chance to answer your questions and address your comments. Dr. Florencia Greer is a professor of clinical obstetrics and gynecology who serves as chief of the Division of General OB/GYN at Penn Medicine. She is a native of Philadelphia who went on to graduate from Harvard College and University of Pennsylvania School of Medicine. And she's practiced at NYU and Bellevue hospitals. Best training grounds in the world. She served as residency director and chief and division chief for general OB/GYN at LSU in New Orleans, her husband's hometown. In September 2018, Dr. Polite was recruited back to Penn, and we're so glad that she was. As a clinician myself for many years, I am moved by her passionate words about the privileges of being a clinician allowed into the lives of her patients during their most intimate sexual and reproductive health journeys. Dr. Polite will speak about her groundbreaking work during the COVID pandemic, titled Medical Mistrust and COVID Vaccine Acceptance Rates in the Black Community. Our second panelist is Ashley L. Coleman, the director of Galaei, and it's great to see her at the helm because I was around for the founding of Galaei with David Costa during the earliest days. It's the Gay and Lesbian AIDS Education Initiative. And you notice I can say it really quickly because I worked with that group for many years. This is an organization that was launched here in Philly to confront the pain, hurt, and fear resulting from loss of LGBTQ Latina lives in Philadelphia to HIV health disparities. And I have been hearing about this remarkable woman for many years. She has been a fixture in the LGBTQ community in Philadelphia for more than 10 years. And she has worked to make LGBTQ events and experiences safe and equitable for all. And she proudly served as General Conference Coordinator of the world's largest trans-Pacific conference from July 2016 to 2019, from 2016 to 2019. She's also multi-talented because she has written and produced a production called Musical Microaggressions, performed to accolades at Washington College. Seems like there's a theme there, Ashley. Ashley will speak of her work to lead this Galaei, this radical anti-white supremacy social justice organization, and the need for authentic, affirming services and education. Ashley is dedicated to creating opportunities, social progress, and amplifying the voices of those most marginalized in our communities. It's so wonderful to meet you both and looking forward to hearing from you both. And now, Dr. Polite, can you please kick us off? Thank you both so much.
Thank you so much, Carol, for that wonderful introduction. It is truly an honor to be here today. I'm very much looking forward to hearing what Ashley has to say as well. I saw a snippet of her slides, and I think you all will see that we have some things in common without ever actually having met or discussed our topics today. So I'm going to start off my slides with a quick roadmap. Dealing with the COVID pandemic in the last 18 months, the past is certainly the present. And I think we have to understand our past to understand how we got to where we are right now with regards to the COVID infection rates in the Black community, as well as the COVID vaccination acceptance rates in the Black community. And finally, I'm going to share a little bit with you all about how Penn Medicine has addressed vaccine inequities by putting race at the forefront. So the Tuskegee experiment has come up a lot, and I think we've heard it mentioned in the last at least year since the vaccine has come up. And I think it's important to sort of start here because this was by many accounts, the most egregious ways that the government has treated the Black community. This is a 40-year experiment involving 399 Black men with syphilis, Black men and some women actually, and 201 without, where they thought they were being treated for bad blood, which could mean anything from anemia to syphilis. But the most important thing to note was that in 1943, penicillin became widely available, and these men continued to be untreated so that we in medicine could witness and bear what happens when syphilis goes untreated. And we learned a lot about primary, secondary, and tertiary syphilis, but at the expense of those who were in the Tuskegee experiment. But this is the start, right? This isn't where we are now. Unfortunately, in medicine, we know that there are many ways that we continue to disenfranchise Black people in the healthcare system, starting with pain management, which I think is important when we look at this one, simply because this was a few years ago that they looked at 40% of first and second year medical students who endorsed the belief that Black people's skin was thicker than white people's. And unfortunately, that false belief translated into Black people being perceived as being less sensitive to pain and thus having pain that was not properly treated. But let's move on to cancers. Almost every cancer in this country has a higher death rate if we looked at the Black population compared to everyone else. And when we think about race as just a construct, we have to imagine what are the contextual constructs that we've set up that allow us, if you're looking at this map here, Black is the blue triangles, white is the reference or the red, to die at a higher rate in men who have lung cancer and men who have prostate cancer by many folds, men with rectal cancer, women with breast cancer, and women with colorectal cancer, right? So what's the takeaway here? That being Black with cancer leads to a higher mortality rate in almost every cancer that's possible. The good news is that the disparities seem to be decreasing when we watch those curves start to come, to a straight line together. But this is over years and years that we have seen this. And I'm an OBGYN by trade, as you all heard. And so when we think about what pregnancy-related mortality looks like for the Black community, it's really deplorable. When we think about the non-Latinx Black community dying at 40 per 100,000 live births, and this is looking at maternal mortality, not infant mortality, compared to our white counterparts at 12 of 100,000. And what's really interesting, and the first time I heard this was almost, literally almost a decade ago, that the idea that being college educated and having access to healthcare does not actually protect you if you are a Black woman. So when we actually look at this grid as we go to the right, it's the attainment of education. And in most cases, you can see that the mortality decreases. But for Black women who are college educated, we're still looking at 40 deaths per 100,000. So how is it that we got here, right? How is it that we have, quite frankly, by many accounts, allowed Black women to die in pregnancy? And the thought is that, again, if race is just a social construct, then what are the ways that Black women specifically are dealing with chronic stress and the implicit bias that the healthcare system has towards them, and thus the racism that they experience at the hands of the healthcare system? But there's also resource allocation, and there's studies that show that the lack of representation in the medical profession by people of color has been shown to actually continue with poor outcomes. So from COVID-19 perspective, I will tell you all that I've identified this as the three-headed beast. The first being that Black and Latinx communities are dying at 2 to 3 times the rate of white communities. This is really important to recognize that this is from racism, not race. There's nothing inherently different about us that makes us more likely to die from COVID-19. But if we think about the types of jobs that we might have in this society, right, more likely to be working in public transportation or in the grocery stores or in many of the places where PPE was not, immediately readily available at the beginning of the pandemic. We also are likely to have 2 and 3 generation homes where maybe the high school student goes and gets COVID, and they're quite frankly going to be okay, but they bring it home to grandma who has diabetes and high blood pressure and is obese and now has a higher rate of actually dying from COVID-19. There's also been, we look at number 3, disparate vaccine uptake across the country. So when we think about the drugstores that originally had the vaccine that were really more present in the suburbs as opposed to the cities, and people were not actually able to get to the vaccine, which was an access issue, as opposed to number 2, which is the one that we are by all means still dealing with, which is hesitancy, this decreased vaccination uptake due to mistrust. And so this is a huge thing that I was thinking about a lot in December. I got vaccinated on December 16th, within the first week that the vaccine became available to healthcare workers. And I was literally like tossing and turning. And so I wrote this op-ed about my fear for my Black community who would not actually engage in the vaccine due to our years of historic mistreatment at the hands of the medical profession. And so I turned to some of the Penn medicine leaders and said, I presume a few things, right? That our vaccine uptakes in the hospital might not actually be equal. And the hospital was a great place to look at this because access was not an issue. The vaccine was available to every member of the hospital staff. And within the first month, we saw really impressive disparities in who was uptaking the vaccine. 70% of white staff, while only 30% of Black and Brown employees at Penn would engage in the vaccine. Now, January, again, when I think about healthcare workers, right, we are not talking about healthcare workers who are Black. We're talking about Black people who happen to be healthcare workers. And the way that they interact with this country has everything to do with many ways with our vaccine uptake numbers. My second dose of the vaccine I had administered on January the 6th. And the one thing I took away from that day was this experience in our country will make this vaccine work even harder because we are working to try to tell Black people, this is a vaccine that we believe to be safe. And what they're saying is, show me the data of how our country has actually treated people of color. This was January 5th, where at the time, the rates of Black and Latinx deaths were only 140 compared to about 100 in whites. But we now know that number is now closer to 200 to 230 in Black and Latinx communities. And so I literally became at Penn Medicine a poster child for vaccination education, specifically as a Black physician in dealing with the ways that our community has to actually, the way I viewed it is we need to acknowledge the racism that has occurred in this country, acknowledge the ways that Black people have been mistreated at the hands of healthcare, and then to say, here's still why we would like you to engage in the COVID-19 vaccine. And so with the director of the HUP system, we developed Operation Caveat, called COVID-19 Acceptance, Vaccine Education, and Adoption Task Force. And this educational director is a person who's responsible for everyone from EVS to dietary services to patient transport materials management. And I went to him and said, you know, I'm hearing different things about who this group of staff would want to hear from. Is it your impression that they'd want to hear from any doctors or doctors of color? And he said, they want to hear from you all because the concerns that they have and how they have interacted with the healthcare system means that there's certain things that you all might be able to say that you'd be able to say differently. And so we engaged in a real three-part effort to engage the staff at Penn Medicine who are largely Black in those four groups that I mentioned. The first was this development of a PDF called Why I Decided to Get Vaccinated of only Black healthcare workers at Penn Medicine. And this was given in the one-page invitation with them to be vaccinated. This was our pictures of us getting vaccinated and the reasons why we chose to get vaccinated. At the bottom, we actually addressed some of the COVID-19 myths. In addition, we came up with a full court press educational initiative that was originally just going to run in the break rooms of these particular staff, but now runs throughout the hospital. And if you stood there and watched the entire PowerPoint, you might think that Penn Medicine has a lot of Black physicians, right? Maybe even that we were a Black hospital, but we are overrepresented in this PowerPoint intentionally. There's, you know, less than 4% of physicians in the country are Black. Penn is not particularly unique in any way, you know, better or worse than that stat. But so the PowerPoint shows, again, physicians, and then it actually addresses myths with the next slide being the factual information around the COVID-19 vaccine. We wrote this up in an op-ed in the LA Times called Vaccine Hesitancy, and was actually also featured in the Philadelphia Citizen about why it was important in our vaccine work to put race at the forefront. The most common question that I was asked from people from across the country who heard about our initiative is, how did you get your stats about who was being vaccinated? And my answer to that was, every hospital knows who's getting vaccinated. The question is, what are we doing about the disparity? And the truth in medicine is often we know about disparities, but the question is, what are we actually doing to address said disparities? We ended the week of our Operation Caveat by going to huddles with staff where they were able to have one-on-one questions answered by physicians of color. We had at least 2 physicians, but at least one of them had to be a physician of color. And we ended the week with a vaccine experience in the Black and Brown community at Penn Medicine, a town hall that was viewed by over 700 participants in our healthcare system. And we made this available as well to all of our patients on our website. My favorite part about this town hall was watching our CMO in a white institution say, to my brothers and sisters, like the idea that we are having Black and brown people dying at 2 to 3 times the rate of whites is because of systemic racism, not because of any differences in race, and saying literally, this is how we hopefully can move forward in this COVID-19 pandemic. It was one of the proudest moments I've ever had at Penn Medicine. In addition, Penn went into the community, right? We were hearing that people would not come necessarily in to get vaccinated. Some people would, but not everyone. And so a separate group set up some initiatives to actually go into the community to vaccinate people. Southwest Philly, West Philly, again, one of the best days I've had at Penn Medicine. I vaccinated 80 people, 70 of whom were Black in the community. And one of the people I got to vaccinate was my mom in the top left. So where are we now, right? When we look at the risk of infection, hospitalization, and death compared to white people in the United States, we see the numbers that I mentioned to you all, where Black and Hispanics are 2 to 3 times the rates of whites in terms of death. And when we look at the percent of the population that has received at least one dose of the COVID-19 vaccine, this is information as of a couple of weeks ago, and we still see that the Black community is lagging behind at only 47% receiving at least one dose of the COVID-19 vaccine. So I want to circle back to Tuskegee because, as I mentioned, this is one of the things that I hear a lot about. And what's interesting is I hear a lot of mis and disinformation, right? So where we are now, if you ask this generation who's the Black generation that's particularly anti-vax is not a group that hasn't been vaccinated against other things, right? COVID-19 represents something very different. But one of the things that they'll tell you is that syphilis was injected into people. Not true, right? It was an untreated, but that's what they'll tell you. They also don't know that the survivors of the Tuskegee experiment and their families have actually been very pro COVID-19 vaccination and said, this is not at all what we went through. This is something completely different. I've even heard studies about the Tuskegee Airmen. And I'm like, no, Tuskegee Airmen and syphilis, totally different, right? So when we think about the ways that people are hearing misinformation and disinformation, I will tell you all, many of the Black physicians at Penn Medicine have done what I have done, which is to go out into our communities, into our churches, into our student organizations, and make sure that we are presenting factual information. Because I view this as the biggest war that we are in right now, which is this idea that because someone has an opinion, that opinion equates factual data. And we have to make sure that we are sharing real information. We're also, quite frankly, up against a media stream of people who are very anti-vax, who, quite frankly, have more stock in the community in many ways than physicians do, right? I personally don't actually care what an athlete or an actor says about a vaccine because they're not a source of medical information. But I recognize that a 23-year-old male who doesn't necessarily have a connection to their physician might care more about someone else in the community. So we've even reached out to try to partner with other folks in the community to say, here's why this vaccination stuff is so important. We've encouraged all people, not just physicians, to use our social media platforms for good, right? And for me, that looks like not just posting selfies of the vaccine, but sharing factual information and correcting factually inaccurate information, which quite frankly could be a full-time job. I think we have to continue to educate, especially if we are mandating. We cannot mandate without educating. It is to me, one of the most deplorable things we can do is to tell people who feel disenfranchised that you have to do something. I do believe in mandates, but I think we have to ensure that those mandates come with education, and they have to come with education in many different forms. It has to be one-on-ones. We have to do town halls. We literally have to make sure that every question that someone has, they have the opportunity to have answered. And so I leave my patients now with 3 points. When they say, you can't convince me to get vaccinated, I tell them, my job is not to convince you to get vaccinated. It's to make sure that you have some information to be able to make the best choice for you. One, I tell them 96% of medical doctors in the United States are vaccinated. We are an incredibly diverse group of people who don't even agree on when women should start mammograms, but we have gotten vaccinated. And I go through the 4 years of high school, 4 years of college, 4 years of med school, and why we've come to these decisions. And then to make sure that they realize that we are largely talking right now about a disease that is really only affecting the unvaccinated. And so the idea that 99% of the deaths are happening to unvaccinated people, when they throw me back the Colin Powell, I say this is simple statistics, right? 1 in 100 10 in 1,000, 100 and 100,000 will still be people who are vaccinated. But what we have to do is address the unvaccinated, because we are still seeing way too many people dying in our hospitals. Every time that I'm on call, we have a pregnant person who has COVID, and we have to talk about the outcomes. I think I did my math wrong, my 1 in 100, 10 in 1,000. Okay. So I want to leave you with that. I want to make sure I have plenty of time for Ashley, who I am really looking forward to getting to share this platform with. Thank you all.
Thank you so much, Dr. Paulette. And thank you for all of the work that you do. It is incredible, and it's impacting our communities in such a positive way. Thank you so much. So as Carol said before, I'm Ashley L. Coleman. My pronouns are she, her, and hers, and I'm the executive director of Galaei. Galaei is a queer, trans, Black, Indigenous, and people of color radical social justice organization here in Philadelphia. It was founded in 1989 under the revolutionary leadership of David Acosta. And much like many grassroots organizations, it was founded with just a handful of community activists who were unwilling to continue to be treated as if their lives and their needs did not matter. At the time, the call for action and advocacy, resources and education was not a request, it was an urgent necessity. Galaei met the needs of the time, created campaigns for healthcare access, bringing testing services into the community and later into North Philadelphia, where there was not previously access to rapid HIV testing. Galaei transitioned from being the Gay and Lesbian AIDS Education Initiative, no longer using the acronym because it no longer represented the communities that we were serving. Galaei evolved several times, changing its mission, moving offices, and now we serve all folks of color and work to bring access, opportunity, and resources and heal historical harm for the most marginalized in our community. Just as we have evolved through the decades, cultivating trust in our communities, we must all evaluate our community's needs and actively work to heal the injustices that have caused medical inequity and mistrust. Today, we're going to talk about medical mistrust, disproportionate treatment of Black and Brown patients, fair treatment, and the results of medical inequity. We'll also talk about what can we do about it? So medical mistrust. We know the touch points around medical mistrust. We have heard the stories, but we as communities, we come to this knowledge in very different ways. Most of our white accomplices learn about the atrocities done to Black and Brown bodies in undergraduate. They learn about electric shock and brain surgeries and amputations and straight up medical murder. They learn about it through books and through documentaries and in the classroom. Thank you so much. We are on slide 3. They see pictures of what is the roots of today's medical procedure as moments in history and not the ongoing mistreatment of folks of color. Folks of color, on the other hand, learn about the dark and frightening foundation of the American medical industrial complex through our families and through our communities. We learn about the experiments of Marie McCarthy or William Aiken, who not only performed deadly, inhumane procedures on those who had no autonomy over their bodies, but did so with absolutely no anesthesia. We Black and Brown children are told the stories of the Tuskegee experiment, of folks who look like us, who were deceived for decades, impacting their families for generations. We were sat down in our living rooms and told of the hundreds of medical professionals, experts, who were involved in carrying out this horrific deception for decades. The same people that we're supposed to trust to heal us. We learn of the US eugenics program that forced sterilization on a documented 60,000 women of color. We're taught of the mass forced sterilization of numbers of Indigenous women in the 70s. Some as young as 11 years old. And now we discuss the allegations of ICE detention centers continuing the same practice of forced sterilization of those that are assigned female at birth between the ages of 10 and 40, as recently as 2020. But do we as medical gatekeepers know how the daily practices that we are doing contribute to medical mistrust? The number one way that medical mistrust is cultivated in 2021 is how we speak to our clients and patients, and even more so, how we listen. Here in Philadelphia, folks of color comprise 66% of the population. How are we supposed to how are we supposed to change for the majority of our population what trust looks like when it has been decimated and continues to be decimated? The passive actions of inclusion are not working. They are empty platitudes to peoples who have been harmed since our ancestors stepped foot off of ships onto American soil. It is not good enough to just examine and change our marketing materials or our websites or what's on the walls of our organizations or clinics or hospitals. It's not only providing CDC printed materials in our waiting rooms or even just having them available in Spanish. It is believing folks of color when they tell you their experience and speaking to them as the experts in their own medical history. Bias is high among medical professionals, and assumptions are killing our Black and Brown community members. Slide 4, please. I want to tell you a story of an experience of someone close in my life. Let's call him David. This took place in 2018. David is a Black trans man in his 40s with no health insurance. His fever was 104.2. He was weak, could barely stand, and passed out on the way to the emergency room. When we got there, the first thing they did was give him an HIV test. It came back non-reactive. He received his first of 15 blood transfusions that evening. He was admitted and put into a sealed room. I was given a gown and gloves and a mask, which I wore for the first time in my life, whenever I entered the room. David was terrified as he went through extensive testing. Both his red and white blood cell counts were so low, they didn't know how he was alive. A week later, and 10 blood transfusions, 3 more non-reactive HIV tests. We were still in the hospital, and David was not any better. Watching him slowly die, I spent significant time at the nurse's desk, requesting for them to use the proper pronouns, advocating to see a doctor more than once a day, requesting for him to be able to bathe, begging for test results. The doctors, when in the room, would not speak to darker-skinned David, who was coherent and capable of making his own medical decisions. Instead, they directed their communication to me. I knew this was colorism, and I just kept pushing in hopes to save his life. On that following Tuesday, an infectious disease doctor walked in. Neither of us had ever seen him before. He immediately misgendered David and made a comment about his name on the wall not matching his chart. David explained he was a trans man, and the doctor had a visceral reaction. The doctor glared at David's chart, and instead of focusing on the tests that had already been done and come back negative, he proclaimed, you're a patient at Mazzoni Center. That's an HIV clinic. Do you have HIV? I was floored. He had all the information he needed in his hands. And also, Mazzoni Center is a queer health center that is one of the few places where we can get affirmative care as queer folks. This doctor was wasting precious time and David's limited energy arguing to reinforce his biased opinion. I advised the doctor to examine David's chart and medical records. He shook his head at me and ordered yet another HIV test. Once again, David came back non-reactive. This doctor made David feel as if he wasn't even in the room. His assumptions costing money, costing labor, energy, and the depletion of David's hope. At this point, he just wanted to leave. It was day 12 before a Black nurse finally showed us where David could bathe. 12 days of asking and being ignored. 12 days of doctors and tests and transphobia and filth. David didn't care about treatment anymore. He just wanted out of that hospital. He knew he was going to die because no one was listening to anything he said. 5 more days in the hospital, and it turns out that David has a genetic disorder where his blood cells are too small. I have not been able to convince David to go back to the doctor since then. He is terrified of dealing with doctors and nurses. Had that doctor set down his own feelings of who David is, asked more questions, and listened, this entire situation would have been different. David left the hospital, and the first thing he said to me was, "They just don't care about Black people." I couldn't counter his feelings. How could any of us blame him for feeling that way? That was my takeaway as well. Next slide. The first place I went to unpack the barriers in healthcare access was my frontline staff. I sat down with each of them and discussed the medical barriers for them, as well as the individuals that are our clients and patients that we serve. My staff is entirely comprised of queer, trans, Black, Indigenous, and people of color under the age of 30 years old, the exact demographic that has the highest rates of COVID-19 vaccine hesitancy and are both the present and the future of fighting for equity in healthcare. 2 main themes emerged. One being the lack of knowledge on how to obtain affordable healthcare. This includes feeling overwhelmed by the marketplace, overwhelmed by medical providers' advice, especially when they use language that is outdated or infantilizing, and the vast well that is Google. The other theme that kept occurring was competent care. Each and every staff member spoke of how they did not have health care before working at Galaei. They, even being below the poverty line, the complicated systems and the multiple attempts at navigating the marketplace was a deterrent. Seeing monthly costs that would make them unable to feed their families made it impossible. I myself was included in their sentiment. I did not have health insurance between the ages of 18 and 32 years old. $80 a month meant an entire week that I could not afford groceries or I couldn't get to work. It felt completely inaccessible. So I, just like my staff, went without going to the doctor for a decade and just hoped that nothing was going wrong in my body. Here we are many years later, and Black and brown, queer and trans folks are still having an identical experience. My staff spoke of the responsibility of community-based organizations to provide free screenings and checkups to just keep the baseline of health needs for our community members. How our clients and patients were frightened to go to the hospital system because of the way they had been treated in the past. We spoke of the major funders and how they're moving funding sources away from CBOs and into the medical institutions and hospital systems, and how this has increased our numbers of clients and patients but decreased the resources. I'll use my own organization, for example. When Galaei was funded to provide HIV and STI testing and linkage to care, if someone was found to be reactive, the same tester went with each and every client and patient to their first 5 medical appointments. We paid for travel. We had their medication sent to our location if they didn't have permanent residency, and physically held the hands of folks who look like us and may have walked away from care because of medical mistrust and fear of subpar treatment. Each and every individual had a human that they could lean on through the entire process that yielded a 100% linkage to care rate for our organization. When our main funder discontinued our HIV and STI testing program, I watched my staff scramble, looking for an alternate way to provide the life-saving services to the marginalized communities in North Philadelphia that would now have to use vital resources to travel to Center City for HIV and STI screenings. We began beefing up our OraQuick supplies and attempting to figure out how we could still offer one-on-one linkage to care. That week that our HIV services were defunded, 2 individuals were found to be reactive. Devastated by the thought that we would not be able to provide testing and linkage to care that was so obviously needed, our young Black and brown, bilingual, queer staff found an external organization to provide testing several times a month in our building. But this partnership is a Band-Aid on an infected wound. We trained their employees and were there to provide help during counseling sessions. However, that one-on-one approach can't exist under this partnership. We watched the linkage to care rate drop. At the end of the day, trust in the medical industrial complex is going to take decades to heal. But in the meantime, it's going to take the active effort of all of us collectively. This includes funders, community-based organizations, private practices, those in medical institutions and hospital systems to create and provide access to competent healthcare services, access to education on procuring insurance, and resources needed to obtain healthcare services. Competent care is not only about knowing the difference between AMAB and sexual identity. Competent care is a lifelong commitment that we have all made. Next slide. So what are the results? The results of medical mistrust and medical inequity are higher infant mortality rates for folks of color. There are higher rates of untreated HIV and STIs, higher rates of death of preventable diseases, undiagnosed treatable genetic disorders, higher rates of institutionalization for untreated mental health issues, mistrust in not only the system, but individual doctors and nurses, and continuing the systemic oppression of the highest population of people in our city. Next slide, please. We see the results of medical inequity and mistrust. The results are death. If we are truly committed to changing these numbers, then each of us in our unique positions must change the way we interact with people who don't look like us. Our jobs are hard and frustrating. There never seems to be enough resources or people or time to heal everyone who needs us. But that is what we signed up for. We signed up to do better, to keep learning, evolving, and increasing our empathy with each passing year. Next slide, please. So what can we do? Ask more questions. Believe your patients and clients. If they say their pain level is a 10 out of 10, then their pain level is a 10 out of 10. Use the name and pronouns they identify with. If you make a mistake, apologize and try harder. Affirming your clients' and patients' identity will allow for open communication. It shows you care about them as a person and that you are moving in their best interest. When you are obtaining CEUs and CMEs every year, don't just renew with the same conferences and workshops that you have for the last 20 years. Research CEUs and CMEs that are available that are specifically on the needs of marginalized and underserved populations. There are spaces such as the Philadelphia Trans Wellness Conference, the World Professional Association of Transgender Health, or the State of Black Health Conference. Diversifying your continued learning not only will make you a better provider, but it will save someone's life. It will build the trust necessary for community wellness and will bridge the gaps in medical inequity. It is the duty of us as gatekeepers, those who can make the active change within the exam room, the hospital, or even the waiting room, to continue to make a way for our patients, to give more access to those who are marginalized. Provide relatable materials, just like this amazing doctor was talking about, for folks that have mistrust. Provide materials from vetted sources that use language that doesn't come from medical textbooks. There's a Medium article that one of the descendants of the Tuskegee experiments, Joyce Christian, is quoted saying, because of what happened during the syphilis study at Tuskegee, an institutional review board was created. And part of that board is responsible for analyzing and approving COVID-19 vaccines. I think our Father would want us to step out on faith. We have been brought to our knees and we need to stand together and we need to seek relief. I sent that article to family members who were refusing to get vaccinated. Within days of reading that one article, my entire family was vaccinated. Take the time to walk through each individual possibility all the way through the process of procuring health insurance or affordable options for your patients. If you do not have someone in your clinic or hospital or medical center that can take the time to provide this life-saving necessity, then partner with the CBO and help fund that CBO, and they'll take the labor on for you. Do your own research on healthcare providers of marginalized communities. Shadow them if possible. Even if you've been doing this for 20 years, the Black Doctors Consortium has been so successful, not only because of the identities of the doctors and nurses administering the COVID-19 vaccine, but because they took the time to speak with individuals about hesitancy, answer questions no matter how wild they seemed, and give comfort in moments of fear during a global pandemic. It is each of our responsibilities to be active participants in building the trust between medical providers and Black and Brown communities. Listen and take notes. Assumptions are unintentional, so you must question every one of your findings. Read and reread your patient's medical histories and question notes that are incongruent with their medical journey. Ask questions to gain information, not to justify your hypothesis. All of this is going to take longer, and it will also build individual and collective trust. Talk openly about the barriers to care and medical mistrust. This work will be uncomfortable, especially as we in healthcare systems work to address factors like racism that contribute to implicit bias. However, to move forward and regain trust, we must acknowledge the historical harm, accept the responsibility for past injustices and unethical research practices, and work to end the current injustices like widespread medical errors and disparities in quality of care. And most of all, remember, your patients and clients are the experts in their own lived medical experience. Next slide, please. And know that I am a resource. My staff is a resource. Feel free to contact us in any of the ways on the screen. Thank you so much.
And welcome back to our question and answer session. And weren't those amazing presentations by these two phenomenal people? I am just so impressed by your passion. I know it's, so everybody take a deep breath, and we got a long way to go here. We got a long, long way to go here fighting. I know I've been in this struggle for many, many years, and seems like we just have to start all over again sometimes, doesn't it? As you both pointed out, Tuskegee, many people do not really understand the true history of the Tuskegee experiments, and mistakenly believe that people were injected with syphilis. In fact, it was really an experiment in withholding treatment. That's what it was an experiment in, which should never, ever happen again. We in Philadelphia have struggled a lot also with, as you point out, and as somebody, I happen to sit on the board of a system of comprehensive federally qualified health centers. And so we really want people to understand that it is their right to treatment, their right to healthcare. How, and I'd like to throw this to both of you. Ashley, why don't you start, and then Dr. Polite can go. How do we change the perception from being fearful? I mean, of course, fear is based on the reality, but how do we how do we change it from, I don't want to get that, but I do deserve the right to get treatment? So Ashley, I'm going to call on you to address that.
Thank you so much, Carol. Yeah, truthfully, it is about sitting down and having those one-to-one conversations. I think about staff members that were doing foot outreach, and especially working with Black and Brown folks who don't have permanent residency, and sitting down and taking an hour, sometimes two, and just going back and forth with them, and then physically walking them to the clinic to get their COVID-19 vaccine, and then sitting with them the whole way through, and also telling them their own stories. I thought it was really powerful when this amazing doctor was telling us about how, they had gotten vaccinated, and then they can move and tell that story to other folks of how they had been vaccinated. And so that in and of itself is going into spaces and saying, I made this decision for myself. It was best for me, for my family and my community. These are the reasons why I got vaccinated. People relate with that, and it really builds the trust.
Mm-hmm. So you're talking about one-on-one and the importance of one-on-one. And Dr. Polite, if you want to respond to that question as well.
Yeah, I'm going to go back to something else that Ashley said, which is that we have to actually change the institutions, right? I mean, I think people view healthcare as a privilege because in this country, quite frankly, it is a privilege, right? We have not ever treated healthcare as if it is an inalienable right. The idea that someone can come into the hospital center and not be treated or called by the name that they'd like to be called by is fundamental in actually identifying somebody's, validating somebody's humaneness and saying this is a place for you. If we don't do that in our healthcare centers, how have we actually said to someone, you deserve care? Instead, what we have is people from the LGBTQ community, people from the minority communities who come into the healthcare space and are told in one way, sometimes directly, sometimes indirectly, this is actually not a place for you. And so how do we, as an institution of a healthcare system, change that narrative? How do we say we actually are a place of healing? We are a place that actually values you, your story, your history, and we want to move forward. And I think institutional change absolutely starts with one person, but it does actually have to be at the level of saying, this is something that the entire healthcare system is going to start working on.
Thank you. When I was an LPN training in 1970, you meet doctors and I'm like, why do these people go into healthcare? They are, excuse me, pigs. And I've been heartened by the fact that since I started my career, there are many more young, they're young, but they're people of color, many more women than there ever were before. I just have to know it's better now than it was back in 1971 when we were in the throes of sterilization abuse. We were in the mental health, but you outlined it very well, Ashley, so I don't have to go over the horrors, but I'm just wondering what's changed and what is our hope for the future of our clinicians and our institutions?
So, I'll start with this one. I think, Ashley's point about where we are, she's mentioned where we need to go, right? But have we actually made some advancements? Sure. The point is, it's just not enough, right? The more people who you actually have at the table, though, the better, to me, the outcome happens, right? Imagine if Ashley's friend had actually seen any member of a healthcare team who started off by saying, hi, my name is Dr. Puli, and I go by the pronouns she, her, hers. How differently would that entire interaction have been, right? And so this idea of sometimes we mess up, but we have to be humble enough to say, sorry, I messed that up, right? Sorry, I made that assumption. Let me actually start this interaction again, because I really do want to make sure that we want you to feel comfortable in that space. I do think it changes as people look around and see doctors and nurses who look like them. I do think the idea that women are not just in healthcare, but are now in leadership positions. I know for sure that it matters that medical students and residents get to see, I've been a residency director, I've been the chief of a division, get to see someone who looks like them. And so that's why personally I stay in academic medicine, because part of my legacy is actually increasing the number of Black and brown doctors in our healthcare system. That is actually what I am directly tied to, is what I want to change by the time I leave medicine. But in the 20 years that I've been here, if I'm in the hospital, a day doesn't go by that someone doesn't make an assumption that I am something that is not a doctor, right? And my job is to change those assumptions. And I've had some really positive interactions where people say, oh, you must be really busy up on the floor, doing nursing things. And I'm like, actually, I'm a doctor. I'm the chief of the division. And I had an old white guy say, I'm really sorry about that. He was like, I'm a 50-year-old white guy. Like, I have my assumptions. And I said, and that's okay. My job is to help you change those, right? Like, so that the next time you see someone, you don't make an assumption about who they are. But they actually do have to see us in these spaces in order to actually challenge said assumptions. So I think it has changed, but Ashley and I are on the same page that we're not where we need to be. We're not where we want to be. But I always tell people, it took us 400 years to get here. We're not going to change overnight, right? We have to be willing to put the work in, but we also have to understand it's going to take some time.
Absolutely. As you were talking, I had this sort of light bulb moment where we need folks just like you to be going into our high schools and our middle schools and recruiting in the same way we do for sports in colleges, recruiting doctors and nurses and folks in leadership that look like us, and telling these stories to the youth that don't know that this is an option. It would be a game changer for the future if we can start investing in our youngins right now and showing them that this is a possibility. I think it would also start to break down some of those assumptions as the white kids in those classrooms are seeing folks like us in leadership and doing the work that we do. So I think this might be a new project for us. I don't know.
I certainly have been invited into a number of high schools, Ashley, and I go for that exact reason. I think it's important for the Black students, as you said, but it's just as important for the white students, right? Because it challenges their perceptions as well. And so I revel in any of those opportunities, not just for the education, because the STD education and the contraception education to me is usually pretty deplorable in schools, right? We should be empowering people to be able to make choices about their own bodies, but just being able to be in those spaces and have someone's brain click to say, well, when I want to go say all Black women are like this, there's a certain person who's there, who's continually challenging that perception.
Well, I guess it's time to wrap up this wonderful panel. I want to thank both of our panelists, Ashley Coleman and Dr. Florencia Greer. It was a very exciting panel for me. So thank you so much. And hopefully we'll get to meet in the flesh sometime. I'd love that. Wouldn't that be nice? So we are going to have a 10-minute break now. So we will see you at the other side of 10 minutes. Thank you all so much.